This video is informational in nature and is intended as a companion tool to the AAOMS Office Anesthesia Evaluation Manual, the comprehensive reference for the OMS office. The video does not intend or purport to set any standard of care. Rather, the video provides a framework for an OMS office and depicts how a well-organized team might respond to medical and anesthetic emergencies in the OMS office. Oral and maxillofacial surgeons must exercise their own clinical and professional judgment depending on each individual patient's clinical circumstances. The operating area must be large enough to accommodate an operating table or appropriate dental chair, the necessary surgical and anesthesia equipment, and still permit the anesthesia team to move freely about the patient, especially during the management of emergencies. The walls, floors, and working surfaces should be designed to permit easy identification and cleaning of contaminants. A width of no less than 36 inches in all entry doors and doors to treatment rooms is recommended. This provides easy access for emergency equipment and facilitates the movement of patients to and from the operating room in a wheelchair or ambulatory. The operating table or chair should feel comfortable to the patient, but more importantly, must permit appropriate positioning of the patient in the case of an emergency. The structure of the chair should be firm enough to permit the delivery of basic life support techniques. If not, a backboard should be immediately available for this use. The operating room lights must provide excellent visualization of the surgical field, while the room lighting should provide appropriate visualization of the entire patient during anesthesia delivery. In the event of a power failure, a battery-powered backup lighting system must be available. This system must be of sufficient intensity and duration to allow completion of the surgical procedure and safe delivery of anesthesia. Suction must be available during surgical treatment and anesthesia delivery. A central suction unit allowing appropriate evacuation and cleaning is preferred. A backup unit must be available should a power outage occur. There are many types of machines available to assist in the delivery of anesthesia. Some provide nitrous oxide, others potent inhalation agents. The one true requirement is the ability of the equipment to deliver oxygen at a concentration of 100% with positive pressure in the case of an emergency. All anesthesia machines must be checked and calibrated on a regular basis as mandated by your state and in conformance with the manufacturer's recommendations. The most important monitor is the anesthesia team. Continuous observation of the patient throughout treatment assures the team that the airway, breathing, and circulatory needs of the patient, the ABC needs, are being met. Electronic monitors help maximize patient care. AAOMS recommends the use of monitoring techniques in accordance with the Parameters of Care Clinical Practice Guidelines, Anesthesia in Outpatient Facilities. The team can gain valuable information about patient ventilation by observing the patient's chest wall excursions, the movement of the reservoir bag, and by using a pretracheal stethoscope. For the surgeon providing endotracheal or LMA anesthesia, the monitoring of expired CO2 throughout the procedure and until extubation is required. The use of capnography should be considered in all anesthetics, including moderate sedation and in non-intubated patients. Beginning in 2014, the AAOMS Office Anesthesia Evaluation will include monitoring of end-tidal CO2 for all patients under moderate and deep sedation and general anesthesia, unless precluded by the nature of the patient, procedure, or equipment. Pulse oximetry is considered the standard of care for evaluating the patient's oxygenation during anesthesia delivery, from moderate sedation to general anesthesia. In addition, the team continuously observes patient color, including the skin, mucous membranes, blood, and nail beds. The team can observe the cardiovascular status of the patient by the use of a precordial stethoscope, palpation of pulse strength and rate, and the use of a manual blood pressure device. To assist the team's observation, automatic blood pressure machines provide sequenced or emergent readings. The BP readings should be a part of the permanent record. In a similar manner, an ECG provides time-specific information regarding the patient's cardiac status and can be used as a permanent record as well. Continuous temperature monitoring may be considered and is essential when using the potential triggers of malignant hyperthermia, succinylcholine, and volatile inhalation agents. Patient recovery may occur in the operating suite or in a separate recovery room. The patient must be monitored during recovery, and when a separate area is used, this room must allow direct observation of the patient at all times. The recovery area must be equipped with a source of oxygen under pressure and suction equipment, and provide adequate space and lighting for the delivery of emergency care. It's essential to have a central work area where anesthetic medications can be securely stored and prepared for use under sterile conditions. Narcotics and other scheduled drugs must be appropriately cataloged and stored in a lockbox or safe. Check with your state DEA for appropriate guidelines. The storage of gas cylinders will vary depending on local building and plumbing codes. Most commonly, the larger tanks are stored in a remote area where they are easily accessible for changing. An audible warning device or visible monitoring of the oxygen pressure gauges is required to alert staff when reserve tanks are being used and supplies need to be replaced. The emergency cart should be located centrally in the surgery area to allow quick retrieval and rapid access to all areas of the office. If a defibrillator is not available in the treatment rooms, the emergency cart is an ideal location for it. Either a manual or automatic external defibrillator is acceptable. An in-depth knowledge of the defibrillator's functions and limitations is essential. Each office will have a particular way of organizing emergency materials. An excellent way to manage this information is with a ring binder or folder that catalogs drugs and emergency equipment. If anesthesia is delivered to children, a separate ring binder is recommended, since drug dosages and treatment may be different for pediatric patients. Appropriately sized emergency equipment, such as pediatric paddles, ambu bags, airway adjuncts, and laryngoscope blades, must be immediately available in the OMS office where pediatric patients are treated. The cart can be arranged in such a manner that the first-line drugs and airway equipment are the most easily accessible. First-line drugs like epinephrine, atropine, and a Medihaler should be immediately available and clearly marked. Succinylcholine should not be stored long-term in the emergency cart because it requires refrigeration. The necessary equipment for airway management is essential. The team must have immediate access to an array of oral and nasal airways, an LMA, a laryngoscope, appropriate endotracheal tubes, stylets, and McGill forceps. The remaining emergency items, including IV solutions, second-line drugs, and so forth, should be placed where convenient. A backup light source or flashlight is appropriate in the emergency cart. Documentation is one of the most important aspects of anesthesia care. A database must be established for every patient. Sample forms can be obtained from the OMS National Insurance Company, and examples are also available in the Office Anesthesia Evaluation Manual and on the AAOMS website. Regardless of the format used, the record must contain 4 types of information. These are the patient information record, the patient health history, a consent form for both the planned surgery and anesthetic, and the anesthesia record. The AAOMS Office Anesthesia Evaluation Manual contains samples of a patient health history form and an anesthetic record.
Okay, ladies, we're here to remove four-impacted third molars with general anesthesia. Does everyone agree?
Yes, sir.
Okay, let's go ahead and get started with the local.
Consideration should be given to taking a timeout before surgery to confirm the patient's identity, the planned procedure, and the site. During the anesthesia event, keep a time-specific log. This log must include NPO status, the monitors used, time and dose-specific delivery of medications, and any and all complications in treatment. Establish a recovery protocol and include it on the anesthesia record to document patient status prior to discharge. The Committee on Anesthesia recommends that all members of the anesthesia team take the appropriate precautions to protect themselves and their patients from the transmission of disease, particularly through contact with blood or saliva. Scrubs with long sleeves, protective eyewear, a face mask, and appropriate gloves are recommended for the surgical anesthesia team.